Hey love, so I want to record a quick video, and this is going to be because it was requested by Red the Educated Beauty, a subscriber who's been following me for a while, and she actually graduated and got into the ICU. Congratulations, love. I'm very happy for you. But she asked me some of the things that she would like to know about what to expect when starting in the ICU. So I'm going to make a few videos, and I'm going to touch on each subject to kind of help you out. I'm using my phone because I can't find the charge to my camera, so I apologize for the quality of the video. But the first thing that she asked for was how to give report. But I think the thing that I learned the most is if you tackle how to take report, giving report becomes a lot easier. My first tip would be is to listen to everyone who gives report. Try to get report from a number of different people and hear how they give you the report. See what they focus on, way that they give the information, what they focus on first, what they give last, and then you can also ask the nurse that you're giving report to. Once you're finished giving report, did you miss anything? Is there anything that you wish that they wish that you would have touched on? And that's what I did when I started, because giving report was probably one of the biggest issues for me. It was that I didn't know how to give report. I worked in an urgent care for a year, and I was only a nurse, so there was never any kind of handoff for me to give. So coming into the ICU, it was really important for me to learn how to give report and also how to take report, because I felt like that was something I was really nervous about, because I wanted to make sure that I knew what I was doing, but I also got the right information. So first, when taking report, the first thing you're going to want to do is have a report sheet. I currently use the report sheet that my job gives me. I found this to work best for me because I tried a number of different report sheets and none of them really worked the way in which I wanted to. I tried to create my own, I put them in different areas, and it was still nice, but then once you ran out of the sheet or if you forgot to copy it, then you're still left with a blank piece of paper and you have nothing. So I just figured it's a lot easier to utilize what the job is already provided, because it already has my patient's information, their past medical history, their consults, allergies, all that's there. And then they have like a little box that allows for you to input information for their assessment. So it works good for me. If your job does not have that, then I would recommend making a report sheet because it kind of flows better in your own mind when you have a report sheet that you created, because then you know where to put the information and then you know what information that you would like to focus on as a nurse. So the first thing I would say when you're taking report is have your pen and paper, and what I first do is I highlight my patient's name, I highlight their allergies, their code status, family contact number. In the event that there is an emergency and your paper is sitting down and you're in the room, you can't get out and you need someone to call the family member or you need someone to check an allergy for you or anything like that, the information is right there, it's highlighted, it's easy for everyone else to see when they grab your paper. That being said, never leave your report sheet out in the open that family members or visitors can see it. I keep my papers folded up when they're not in use, and then I keep them onto the side underneath like a clipboard or something, or I keep it in my pocket so that I know that the information is not being left out. So then the second thing I would say is that when you're taking report is how I generally give report is I start from head to toe. So most likely if it's a seasoned nurse and experienced nurse, they generally do it the same way because it just tends to make sense. But if they don't, some nurses, still kind of go all over the place, and you just have to know where your sections are. That way you're able to write as they talk. And, people want to hurry up and get out of work. So report can be very fast. So you may feel like you don't know where to put everything. So you're kind of writing in the wrong places, or you're writing in an area that doesn't fit. So sometimes I will rewrite my report sheet just so that it makes sense to me. But also don't be afraid to ask the nurse who's giving your report to slow down. You never want to miss information because you're worried that, that they're going to be aggravated, that they want to hurry up and go home. Granted, everyone wants to go home. It's a long 12-hour shift. But you need to make sure that you have everything that you need, because that is the most important thing for you to take care of your patient. So the next thing I do on my report sheet is I look over their past medical history and their past surgical history. This information is important because, in the event that they have maybe a cardiac rhythm that is not what they currently have, you want to know if, does this person normally have AFib, or is this a new onset? You want to know if a patient is having high blood sugars or low blood sugars. Are they hypoglycemic or hyperglycemic? You need to know if they have diabetes. You need to know if they're insulin dependent. You need to know all of that information. So having a background of where the patient is gives you an idea of how to care for the patient. The next thing that I focus on is the neuro. When I take report, the first thing that I want to know is my patient awake, alert, oriented, times 1, times 2, times 3, or if they're sedated because they're on a vent, or if they are unresponsive, so that means no sedation at all, but they're just, in a coma. I need to know what my patient's status is like, and this is important because you want to know what to expect when you're going into the patient, and you want to establish a baseline, but you also want to know what the nurse had previously. That way, if there's any changes in the patient's status, you know when the change happened. If it's going to be on your shift or if this happened previously, you need to know that. Orientation to self, to the time, which is like date, and then the place or where they are. So when I go in, I talk to my patients, I name their age, and I ask them today's date, and then I'll ask them if they know where they are. Sometimes I'll throw in another question because, it's hard. Patients do get mixed up with dates because they are in there for a while, so everything kind of merges into one. But I'll ask something if it's current to time. So I'll ask them, if there was a holiday that recently passed, which holiday just recently passed, or ask them who the president is. Something like that, just to get an idea of if they know what the current situation and current time is right then and there. If my patient is sedated, I'm going to check their Glasgow Coma scale. So you're going to see, what you're going to do is from your head to toe, you're going to see if they have any response to noxious stimuli. So that would be like when you suction them, are they grimacing, or are they moving away their face? If they're going to have any response to pain, so that's like if you push down on their nail beds, if there's any response to that. I'm going to check their eyes. I'm going to see if their pupils are equally reactive to light. I'm going to touch the bottom of their feet, check for reflexes. You're just going to go through the whole neuro assessment just to get an idea of where they're at. So when the nurse gives you a report, you want to know if the patient is following commands, if they're negative for commands, and if they're having any kind of response to noxious stimuli. The next thing I'm focusing on is cardiac. I want to know what my patient's rhythm is. I want to know if my patient is normal sinus tach, if they're having SVTs, which is supraventricular tachycardia, PACs, PVCs, anything like that. You want to know this because this is important, that if the patient is going to have a change in their cardiac rhythm, you need to know what is their normal baseline, or what was their baseline when you got report, and if there was anything different for the nurse previously. So say if a patient had a 4-beat run of VTAC prior to you, and you did not get that in report, and the patient has it again, the doctor's going to ask, has this happened before? And you won't know. So this is important that you ask this information because that can determine how the doctor treats the patient. Also, if there's a change in their cardiac rhythm, sometimes that can be due to electrolytes. So you want to check your strips for previously if anything is a change, so that you know if this is new. The next thing you also want to focus on pulses. They're going to be Doppler, which is like you need the Doppler ultrasound to hear a pulse. It's going to be +1, which is thready, which is difficult to palpate, but you're going to feel it. And then there's +2, which is a normal, and then there's +3, which is bounding. I always check my uppers and lowers. So if my patient has good pulses, which are +2s, I would say they're +2, upper and lower. If my patient has thready lower pulses, then it would be +2 uppers, which are normal pulses at radials, and then +1 for thready pulses in their pedals. Now, if you can't feel pedals, you're going to go to post-tibs. You can't feel post-tibs, you're going to go up higher. And if you still can't feel those, then you're going to go to the Doppler, and that's going to be how you know if there are pulses there. Say if a patient has a leg amputated, now it's only on one leg, you would check the pedal, post-tibs, or whatever on the one that is there, and then you would check the lowest point of where their amputation is. The next thing I would focus on is respiratory. In respiratory, I am looking for if my patient is on a vent. I want to know what their ETT tube is, so that's their endotracheal tube. I want to know what size and where is it placed. So generally, tubes are going to be somewhere between 7.5 to an 8, and then they're going to be positioned, and I think it can go from like 19 to like, I don't know, 23 or something like that. Don't quote me on that. But what you will get in report is that the patient has a 7.5 tube, 21 at the lip. And you are able to confirm that when you look at the patient's tube, you'll see it on the side. It will say the number, and then you'll see numbers with like a little arrow, and then that will tell you where it is at the lip. The tube is also moved for patient comfort and to prevent breakdown. So move from the side to middle to the other side. So you want to know where it is also, because when respiratory comes in, if they're not moving the tube, you want to ask them just to move it over to the other side to prevent breakdown. Then you're going to want to know the vent settings. So typically at night, my patients are on AC, which is assist control. If you don't know your vent settings, I would definitely recommend going over that. I would ask your respiratory therapist, and then I would also read up on it as well. So vent settings, you're going to have first your rate, which is how many breaths the vent is delivering to the patient. The second you're going to have is the tidal volume. The third you're going to have is the FiO2, and the fourth you're going to have is the PEEP. That is how I set up my vent settings. That's how I put my numbers. Sometimes people just write them anyway, but this is what makes the most sense to me. So I may get a patient that is on a vent setting of 20, 400, 30, and 5, which means my patient is getting 20 breaths a minute, their tidal volume is 400, their FiO2 is 30%, and then their PEEP is 5. I would look up each of those terms so that you understand what they are, okay? If my patient's not on a vent and they're just having room air, I just put RA, room air. If my patient's on a nasal cannula, I want to know how many liters they're getting, and then I'm going to say nasal cannula. But if they're on a rebreather, if they're on a venti mask, if they are on an oximizer, any of that, I put that information down. The next thing I would focus on is gastrointestinal. And this is where I would focus on the diet, bowel movement, how the stomach feels. So first, I would want to know if my patient is on a regular diet, if they're on tube feeds, if they are NPO. I want to know that information. If they are on tube feeds, you want to know the rate that they're getting it and what's their goal. You also need to know how much water flushes they're getting. So when the nurse gives you that information, you also want to verify it in the order, because sometimes, orders are changed, and when you go, the patient may be at a rate of 35 getting 100 water flushes, but they've advanced the tube feeds to being 50 mLs an hour, and then only 50 water flushes every Q2 or whatever. So you want to make sure that information is correct. So if they're just on a regular diet, you just put regular diet, you don't worry about that. If it's a mechanical chopped, you're going to be focusing now that if the patient is on a specialized diet, that is probably because they're having aspiration precautions. So if they have a mechanical chopped, if they're on honey thick or kind of thickened liquids or thin liquids, you need to know what causes them to aspirate, because you don't want your patient to choke. So that being said, you need to know what the diet is, because if somebody brings up a tray and they put regular water on there, but your patient is on thickened liquids and they drink that water, that patient will choke. So you need to know what diet they are allowed to have. The next thing I would say to focus on is the bowel movement. You need to know when the last time your patient had a bowel movement. If your patient hasn't pooped for days, the patient's constipated. They're going to need a bowel regimen. You need to know that. But also, if your patient is having frequent bouts of diarrhea, say that this is now the third or fourth time, it is now cluing you in that your patient may have C. diff and you may need to send the stool sample. You also want to know the characteristics of their poop, because you need to know what to look for. If it was hard and formed earlier but is now just runny or watery, or there's mucus in it, you need to know that information so that you can give that information to the doctors and they can prescribe the necessary regimen for them. The next thing I would focus on is GU, which is genitourinary. For that, I want to know if my patient is voiding on their own, or if they have a Foley in, or some type of catheter. It could be a Texas catheter or whatever, or the female Wicks. Whatever they're using, you want to know what is the way that they are voiding, and then how much they're voiding, and then as well as the characteristics. You need to know if your patient is having low urine output, but you also need to know if your patient is having a high urine output. Low urine output may be because the patient is dehydrated, or maybe they have poor kidney function. You need to know all these things. That way, when you're looking at the labs, things start to make sense. If they have a high urine output, you also need to pay attention to their electrolytes, because you need to know if they're now releasing everything out through their urine. So pay attention to these things, because it's very important. The next thing I would focus on, I said the characteristics. That's important. You want to know if the pee is yellow, it's clear, that is a normal thing. If it's cloudy, if there's sediment, if there's blood in your urine, all things you need to know. So you want to know what the patient's baseline is. The next thing I would say to focus on is skin. You want to know if your skin is intact. That is ideal if they have intact skin. You don't have to worry about anything. Prophylactically, at our job, we a lot of times put optiphones on our patients if we start to see a reddened area around their sacrum. So if your patient does have any kind of pressure ulcers, you need to know where it is and what stage it is. This is very important because you don't want a pressure ulcer to happen on your shift. So say if somebody gives you a report and does not tell you there's a pressure ulcer, you go in and you see there's a pressure ulcer, you need to document that at that point in time, because if not, the next time you go to give a report and you tell them there's a pressure ulcer, and now looks like it happened on your shift, and that is now an issue. And then that deals with how the hospital is reimbursed. So you need to know when the pressure ulcer occurred. So you want to make sure you document and you really look over your patient to get an idea of what their baseline is. The next thing I focus on is their ortho, which is how the patient is able to move. Are they independent? Do they need assist? You need to know all that information, because if you have a patient that is in bed and decides to get up and go to the bathroom and they are a one-person assist or needs help to getting to the bathroom or not supposed to get out of the bed, that could be a real issue, because now the patient can fall and that will be on you. And in the hospital, no fall is ever okay. Falls are 100% preventable, so you need to know what your patient is able to do and if you need to be in the room when they do it. So if they do get up to ambulate to the bathroom, you need to know if you need to be there to assist or put an aide in there to assist. But that also says that if your patient is getting out of bed and they are instructed not to get out of the bed, you need to put on socks on the patient. You need to put a fall risk bracelet on them. There needs to be a fall risk alert on the door, and their bed alarm needs to be on. Or you need to put an aide in the room, because you need to protect the patient and also yourself, and you need to make sure that if they're not supposed to get out of the bed, they do not get out of the bed. The next thing I focus on are IVs. I want to know where my IVs are. I want to know what catheter they use, and then I also want to know the date they were put in. Now, you need to check your hospital standards for how long they allow IVs to be in. So once it hits that point, I will try. Doesn't always happen, but I will try to remove an IV that is getting ready to be out of date and put in a new one for the oncoming nurse. That way to make their job easier, especially because I work nights. Sometimes there's a little bit more time for you to get things done. Days are very crazy, so it's nice when people are able to help out the next shift. So definitely pay attention to that. You also want to, when you go in to check your patient, you want to flush all your IVs. You need to know what IVs are working or what's not working. You need to know if it's infiltrated or anything, because God forbid that there is an emergency and the patient is coding and they go to put epi into an IV site that is not working, they're not getting any of that medication. Or if you need to rapidly intubate a patient and they go to sedate the patient and the IV is not working, they're not getting any of the medication, they're not being sedated, and you're trying to tube somebody who's awake and alert, and you don't want that. So always check your IV sites. In the ICU for us, we have 2 IVs. Sometimes you only need 1 on the floor. So I would also get to know what they generally like. I feel that in working in the ICU, it's always nice to have 2 IVs, because in the event one doesn't work, you have another option. Also, when you're giving medications, some medications are not allowed to go with each other, especially lactated ringers or dextrose solutions. They do not fare well with other medications. So having a second IV site will allow you to give an antibiotic and still give them their maintenance fluids in separate sites so that you don't have to worry about crystallization. So definitely know that. Have 2 IV sites. It helps out a lot. The next thing I'm worried about are IV drips. I want to know what medications they're getting. I want to know what rate they're getting them. And I want to know compatible with other medications that you're giving. So if you are giving, let's say normal saline, and it's at 100, you need to make sure that you verify that on the order, that the order doesn't really say D5 in normal saline at 50, because now you're fluid overloading that patient and you're also giving them the wrong fluid. So definitely check what fluids they're supposed to get and what rate they're supposed to get them. So when you go into the patient's room, you want to check the pump and you want to check it with the bag that is hanging. Always do this. You want to make sure what the patient is getting is what they're supposed to get, and you want to make sure it is at the right rate they're supposed to get it. Then you also want to make sure that the medications are getting, if they are piggybacked to each other, or you're connecting one primary set to another primary set through that second port on the IV, you need to make sure that they are compatible. And you're doing this, to prevent any kind of crystallization or any kind of medication reactions when giving the patient the medication. Those are the main things that I look for in an assessment head to toe. I will also want to know if my patient has any blood sugars. I want to know if they're on any fluid restrictions. I want to look at their labs, and I want to know if there's anything I need to do immediately when I start my shift. So I'm going to show you guys what my paper looks like, and I just wrote this on a piece of binder paper just so so you guys can have an idea of what it looks like. I recommend getting a report sheet done, but this is what my paper looks like. So this is a report sheet. You guys can see that I have my name, the age and gender, the admission date. I'd say this is very important because you need to know where to start to focus your report from, so that when a nurse starts to give you information, you want to know, okay, so what happened when they came in on this day and what has happened subsequently. The next thing I'm going to focus on is the code status. Very important. God forbid a patient is to turn for the worst. You need to know if this patient wants to be intubated, if the patient wants to be resuscitated. If not, you do not want to do these things if it's against the patient's wishes. Sometimes people don't know the code status if a patient's coming in off for cardiac arrest and you aren't unable to contact the family. You treat that patient as a full code. But once you are able to determine what the code status is, you need to adhere by it. So you need to know what their status is. This is very, very important. Always know what the code status is for your patient. Consults would be any doctors that are on the case. So they may consult a cardiologist, they may consult a neuro, they may consult a nephrologist. You need to know who the doctor is. That way, if there are any issues, you're able to contact that doctor. The family contact number is also very important. This is in case of an emergency. You need to know who to contact and what number to reach. The next thing you guys can see here is just the past medical history, the past surgical history, and then this is how my assessments look. I just follow it in this way. I go neuro, cardiac, respiratory, GI, GU, skin/ortho, IV drips, and then PRN meds. This is like in the event that anything is happening. Say if your patient is agitated, you want to know if you have an order for Ativan, Haldol, whatever. If your patient has pain, you want to know what medications they're allowed to get and the frequency they're allowed to get it. That way you're able to give your patient some kind of reprieve. So definitely know what PRN meds you have available. That way if you're in the room and you need to get something fast, you can ask a nurse like, hey, can you pull out Haldol or can you pull out Ativan 1 milligram so they can bring you this medication while you're in the room with the patient. The next thing I have is how I typically do it is I put the date the patient was admitted and then I would follow down. So as I'm getting a report, the patient will say, okay, the patient came in on 5:30 and on this day the patient had a PICC line placed. They were intubated, what IV fluids they were given, let's see, anything pertinent that happened, like anything major that happened that day. The patient had a new onset AFib, they started this medication, or they started this antibiotic, or if they DC'd anything, I would put that all on that date. And then I would go do that for each date. The next thing I do is after I'm getting that information, I like to fold my paper in half like this, where I cover up the patient's, information about what has happened so far, just so that this is open here. And I fold this paper and I write at the bottom, I do my Foley's, which is how our job does it. At night, we check their Foley's at 10 p.m. and then again at 6 a.m. So I would do 22 and 06 because we do military time, and then I would write them out. If your patient is on fluid restriction, you would want to put how much fluid you're giving them and then how much is coming out. The next thing, if my patient is on blood sugars, I would put how frequent their blood sugars are. So if they're QID, 7, 11, 4, 9, Q6, whatever, you put that there, and then I put the times that the sugars need to be done. If you get a patient that is on an insulin drip, we do our checks Q1 hour until the doctor feels that the blood sugar is controlled enough to be taken back. So then it'll go like Q2 hours or Q4 hours or whatever the amount is. So if you do have a Q1 hour, make sure you have enough space to take all those sugars down. And then I normally do an arrow right next to the result of the blood sugar and put how many units that was given. The next thing I put are labs. I would put any new labs. Well, first I take labs down when I'm taking a report. I want to know what I'm dealing with when I come on. And then in the morning, I also write down all the new labs results. That way I can give that to the nurse. And then finally, I do my to-do, which is if a nurse is telling me the patient hasn't had a Foley yet, or if the patient needs a new IV in the left AC, or if the patient needs a leg strap to hold their Foley, or if they need a new Optifoam, I write that down because during your shift, it's really easy to forget something that you need to do. So I would say write it down and then just put like a little check box so that you know that you've did it or not. And then, you know, kind of gives you a baseline. So this is what has helped me so far. Every day I'm still learning new things, so I kind of change things as I go along. Like, as for instance, this folding this paper, this is a recent thing. This is something I've been doing maybe for like the past month or two. And I feel like it does help me because it now kind of increases the paper. And I don't have to flip the paper over, which seems lazy. Like, it's super easy to flip the paper over, but it's a lot easier just to have this flipped up that you can, like, oh, you can point to this and then, you know, flip up and here are your labs. And it just makes it easier, especially if you need to call a doctor because your patient is having a new onset of something. You have everything right there. So the report sheet is not only for you to take report, but it's also for you to give report. And then also, if you ever need to tell a doctor anything, you have that information at your fingertips. You always want to be prepared as possible when you're calling a doctor because they need to know that information. And if you are waking up in the middle of the night, you need to make sure that you are giving it to them quickly because they don't really want to be on the phone. So make sure you have everything at your fingertips. That is primarily it. This was a really quick run through. I'm getting ready to go into work, so I just wanted to make this video quickly for you guys so you guys could see it. But if you guys have any questions, let me know, and then I'll try to go in a little bit more. Hope this helps.